Good morning, everyone. Welcome to this week's medicine clinical meeting. I request all the speakers to kindly stay within 10 minutes. We have 6 presentations today. I would like to invite Akash from Medicine 5 for the first presentation.
Good morning, everyone. My topic today is Eat and You Will Fall, and I'm presenting in behalf of Medicine 5. So today, the history is, it is a 24 years old gentleman from Jharkhand. He presented with chief complaints of giddiness for 1 week and increased sweating over his palms and soles during those episodes and palpitations during those episodes. So he was apparently normal 1 week back when he started developing episodic dizziness, which is non-vertiginous, with increased sweating over his palms and soles during those episodes. While elaborating the giddiness, he complains of giddiness, which is especially after the meals, lasting for around 30 minutes up to 1 hour, especially within 1 hour of having meals. And he also complains of feeling increased heat over his body during those episodes. No other complaints like loose stools, flushing, no history of headache, no history of neurological deficits, no other positive complaints. And past history-wise, he is a known case of papillary carcinoma of thyroid and status post total thyroidectomy in 2020, followed by which also his parathyroid glands were not auto-implanted. He is on thyroxine supplements, 150 micrograms, and calcium supplements also, and is not a known ischemic heart disease, no significant family history also. On examination-wise, he is a moderately built gentleman. There is no pallor, no icterus, no cyanosis, clubbing, pedal edema or lymphadenopathy. Vitals-wise, his blood pressure is 100/70. Respiratory rate is 17 and heart rate is 80 per minute, and it was irregular, and JVP was not elevated. And systemic examination wise, CVS, S1 S2 heard and no murmurs. RS, normal vesicular breath sound heard, no added sounds. Per abdomen, it is soft and no organomegaly. And CNS wise, higher motor functions, power, tone, bulk, reflexes were normal. And there are no cerebellar signs, and Romberg's is also negative. And had no meningeal signs, and spine and cranium is also normal. So basic investigations wise, hemoglobin is 12.5, WBCs of 9,400, platelets, RBCs, and total bilirubin was slightly elevated, and urea and creatinine and other investigations were normal. TSH is 0.012, and parathyroid hormone of 19.2, and serum cortisol of 19.7. So what are the possible differential? This is a case of 24 years old man who presented with episodic giddiness, especially after meals, on and off for the 1 week, and also status post total thyroidectomy. Any differentials? Sorry.
No difference. Why episodic is the question? Again, why episodic? Why does refeeding has to happen episodic?
Kind of. Yes. Kind of. Almost kind of. Yes.
You need prolonged fasting for refeeding, so you cannot repeatedly have that.
Yes.
And if it's serotonin, you will get other symptoms, diarrhea, flushing.
So differentials considers vestibular dizziness, benign paroxysmal positional vertigo, postprandial hypoglycemia or hypotension, or orthostatic hypotension, any central causes, metabolic causes because of hypothyroidism associated, any syncope, any vestibular migraine or carcinoid syndrome, or any transient ischemic attacks, or is it a functional dizziness? So initially ENT was consulted either to rule out any peripheral causes or vestibulopathy, which was ruled out. An MRI brain with contrast was also done to rule out central causes. And cardiac monitoring was done to rule out any arrhythmias or bradycardias. And bedside autonomic function test was also normal. And 5-HIAA was also normal. And TSH wise, it is 0.019. And free T4 and T4 was borderline high. And PTH, calcium and phosphate was normal. So postprandial hypotension, is there any postprandial? There is no significant drop in blood pressure during those times. Then we thought of either postprandial hypoglycemia or not. So postprandial sugars were measured during those episodes, but none were significantly low. So then we go ahead with the fasting insulin and C-peptide levels, which were normal. So then we go ahead with a test called mini meal challenge test. So according to this, preprandial insulin and postprandial insulin does not show significant increase after eating. So hence a syndrome called postprandial syndrome was then considered as a probable diagnosis. So what is postprandial hypoglycemia? This is postprandial syndrome. So postprandial hypoglycemia, it's not a diagnosis per se. It describes a timing of hypoglycemia, that is within 4 hours after meals. So if postprandial hypoglycemia is suspected, we should investigate for further causes. So the causes for postprandial hypoglycemia, most common it could be due to insulin or factitious hypoglycemia, either due to insulin or sulfonylureas, or something called gin and tonic hypoglycemia, that is alcohol and tonic when consumed together. It is known to cause hypoglycemia, but the mechanism is not clearly understood. Or any insulinomas or non-insulinoma pancreatitis hypoglycemia syndrome, or insulin autoimmune hypoglycemia, or hereditary fructose intolerance, or some gastric surgeries. So one of this is insulin autoimmune hypoglycemia. It causes spontaneous generation of antibodies to the insulin in response to a meal. So initially after meal, it binds to the insulin and it dissociates in an irregular fashion, so that it later causes postprandial hyperinsulinemia, which was late, and hypoglycemia. And next is NIPHS. So this is a rare syndrome. It is an endogenous hyperinsulinemic hypoglycemia, but it is not caused by insulinoma. So if we took specimens of those people, it showed some beta cell hypertrophy and islet cells were enlarged, and they will have postprandial hypoglycemia with adrenergic symptoms and neuroglycopenic symptoms. And one more thing, this is called some postprandial sympathoadrenal symptoms are reported in people with insulin resistance and very mild to type 2 diabetes mellitus, but the phenomenon was not yet firmly established. So presumed mechanism is supranormal insulin response to a supranormal rise in plasma glucose after glucose ingestion, followed by excessively rapid response to insulin. But in our patient, HbA1c was also normal. So what is this mini meal challenge test? It is actually done for postprandial hypoglycemia. So the patient consumes a mixed meal, followed by which fasting blood glucose, insulin and C-peptide levels are measured, and postprandial sugar, insulin and P-peptide levels are measured. Eventually, it is measured for every 30 minutes up to a level of up to endpoint. One of the endpoint is meet. The endpoint is either the patient developed typical hypoglycemic symptoms or up to 5 hours. So these symptoms, they should be analyzed only if the patient develop hypoglycemic symptoms and the plasma glucose is less than 65 milligram per deciliter. So interpretation wise, actually there is no specific standards for that. Insulin has half-life of 5 minutes in patients with normal kidney function. Therefore, postprandial insulin levels indicate or reflect rate rather than the rate of secretion in response to nutrient ingestion. And suppressed insulin levels can exclude hyperinsulinism. And why C-peptide? It is to distinguish either it is an exogenous or endogenous hyperinsulinism. And if a plasma glucose is less than 65 milligram per deciliter, hypoglycemic disorder is unlikely. So what is postprandial syndrome? So actually in our patient, he suspected postprandial syndrome, because what is this syndrome is, it is observed in patients with symptoms suggestive of hypoglycemia. They will have some sympathoadrenal symptoms, but without concurrent biochemical evidence of hypoglycemia. They will not have low sugars. They will not have decreased insulin levels or C-peptide levels, increased insulin or C-peptide levels, usually after ingestion of a high carbohydrate meal and resolution of the symptoms with dietary modification. So in past, what it was thought is, it is thought because of an exaggerated physiological response. It is not a disease. It is an exaggerated physiological response to our body. It is a kind of functional hyperinsulinism. So there are very limited journals regarding this. This is one of the journal. It was done in 1989. So in this, actually has mentioned, could the brain be registering a hypoglycemic response even though glucose concentrations measured in peripheral blood are not low? So, and also he has mentioned some so abnormalities were observed in a patient with an insulinoma who had low blood glucose concentration, 90 minutes even acting. So what he is coming to say is, so there is no evident hypoglycemia recorded, but the people will have hypoglycemia and sympathoadrenal symptoms. So treatment is actually, we have to we should give frequent meals and snacks. We should not give a high carbohydrate meal. We should give small meals and snacks, consuming foods high in fiber. We should avoid foods containing high sugar. And actually, there is a little quality evidence that any of these dietary patterns can be beneficial. But if the dietary modification is not beneficial, there are some trials also which shows that if you give alpha glucosidase inhibitors, it will delay the carbohydrate reabsorption. So it will decrease the postprandial sugar pickup, leading to decreased insulin response. So now back to our case, it presented with postprandial sympathoadrenergic symptoms, but it did not have evident hypoglycemia. And so we advised dietary modifications, and we added tablet voglibose, followed by within 2 days, the patient symptomatically improved. So thank you all.
Any questions or comments? Can you please explain your mini meal challenge test for this patient and interpret that for us?
So actually, in our patient,
Like this.
So actually we gave him a mixed meal, sir. So
Slides.
We gave mixed meal
That
and
patient's results. Yeah.
So preprandial insulin and C-peptide levels were 8.5 and 2.10, sir. After that, we gave a mixed meal. So we gave here we were following some ensure powder and mixing with water, and asked him to take in he should be in a fasting state before that, and he should take it, and followed by which we should take every 30 minutes usually. Every 30 minutes, so up to a maximum of 5 hours. If he develops some hypoglycemic symptom, we can stop with that until
Your patient developed hypoglycemic
yes,
symptoms.
Sir, he develops that.
Stopped when it was 5 hours.
Yes, sir. He developed the same symptom, giddiness with sympathoadrenal symptoms. So we stopped it, but none of that sugars were lower than that. So I mean, actually, it should be analyzed if the plasma glucose is less than 65.
So did you have a
No, sir.
low less than 65 sugar?
No, sir. No.
So then how do we interpret this mini meal challenge test and come up with such a rare diagnosis called postprandial syndrome? 1. 2, measuring insulin in a normal lab assay is extremely non-sensitive. You need a clamp study to actually say where insulin levels are checked every 5 minutes concurrently with glucose to interpret a insulin level. C-peptide, okay, you've ruled out exogenous and endogenous, but I'm not very aware of this diagnosis, but I don't think your interpretation of your mini meal challenge test nor its place is very appropriate here. Looks like a very exotic diagnosis, but do not seem to have a very foundation for the diagnosis. Because this measurement of what does this postprandial insulin and C-peptide tell us? So, and usually are postprandial syndromes hyperinsulinemic syndromes? Yes, you're seeing you're having hyperinsulinemia, but not having concurrent hypoglycemia. But I'm not seeing any hyperinsulinemia here, nor did your patient have blood sugars less than 65 to even interpret this test. I'm a little concerned about the diagnosis. Any more questions? We'll move on to the next presentation. Ritesh from Medicine 3.
Thank you.